All right. I think for the sake of time, we'll go ahead and get started. A couple of quick housekeeping things. There is the ability to chat and ask questions. It can be a little complicated with using Zoom or the Whova app. So there are a couple ways to do it. The Whova app is probably easiest to kind of keep track of the questions because they also exist after the session. So if you can figure out what the Whova chat is, that's probably the best place to do it, but we will take them any way they come. We also will be recording this session, so it will be available afterwards for you to enjoy or share, as well as being able to view the session that's going on concurrently. So those are probably the biggest housekeeping things for tonight. Otherwise, I will welcome everybody to this conversation. So I'm Caleb Upp. I'm one of the genetics physicians at Helen DeVos Children's Hospital. I am part of the Rare Disease Network team that put together this Rare Disease Day/week events. And it is my distinct pleasure to welcome two colleagues of mine, Dr. Beth Kurt and Dr. Nick Hartog, both from Helen DeVos Children's Hospital. Beth is the section chief for hematology and oncology, and Nick is an allergy and immunology physician and the director of the primary immunodeficiency clinic. And I think one thing that really unites both Dr. Kurt and Dr. Hartog is they are the kind of physician that's willing to ask the extra question. And the extra question is kind of a scary question because it's the question of, well, what else could be going on here? Or what else might we be thinking of? Sort of just that next level of curiosity and looking to take care of patients, particularly patients that have rare diseases. So I thought they would be wonderful people to talk with tonight. Thank you so much for joining us, Beth and Nick.
My pleasure.
Thank you for having us.
All right, so I thought we would maybe start historical and kind of trace our way through maybe your careers a little bit to where we're at now and into the future, and really try to circle around the idea of rare disease and how it's come into your lives, how it's currently in your life, and again, where you kind of see it going. So if maybe we'll start with Beth, looking back maybe before the time where you were actively taking care of rare disease patients like you are now, can you share an experience that maybe you had with rare disease from the past, or is anything that you remember from that at all?
Boy, from the remote past. Honestly, one of the experiences I had kind of earlier in my training as a resident was when I did a medical mission trip, and we went to Tegucigalpa, Honduras, and there met lots of lovely people. But I had met a family who brought their child who had some symptoms that just really, they couldn't understand. And of course, medical resources were quite limited there. And I remember just leaving that experience thinking, gosh, if we could only have been able to do further testing and ask more questions. And I attempted unsuccessfully to petition to bring her to the States just for further evaluation. And unfortunately, that didn't work out. But I do remember that leaving an impression on me, even though I couldn't pursue asking some of those questions, as you say.
Nick, what about you?
Yeah, so I actually do remember early on, back in undergraduate and all of that, as far as the immune system is, it always fascinated me and how complicated it is and how interconnected it is with everything. And so I knew that going in, and but there's lots of different ways within medicine to pursue the immune system. It is important in pretty much every organ system. I'm a little biased when I say that, but it's important. But I remember after my first year of med school, I was doing some basic science research in a mouse lab and at the bench a lot of day with and then in that same lab with two docs that do a lot of primary immune deficiency, are very prominent in our field. And I was doing a lot of work on mice and primary immune deficiency, and knocking out proteins is a really good model to study the immune system. And I had been working most of the summer on this until one day, one of those docs came in and says, "Hey, Nick, like, are you busy right now?" And I'm like, no, we got some time. And he said, "Well, come on over to clinic with me. The mice you've been working on, we've got that patient." And so it was a disease called IPEX. And he's like, "We've got two IPEX patients here to see." And so you can really take what we're trying to do in the mice that day and see, this is how it affects patients. This is what we're studying. This is what we're trying to do. And this is how we can impact that rare patient that we see, and why it interconnects. You really, in immunology, take stuff from the bench to the bedside really quickly and affect those patients with these rare diseases that we don't have huge studies for, and that we really have to do this kind of stuff. And for me, that was that transition. I mean, seeing those patients that day was one of those that really kind of opened my eyes to, like, yeah, wow, like, this is really what I want to do. And that really kind of set the trajectory. Is, somebody simply saying, "Hey, Nick, come on in clinic today."
Awesome. So I think one thing that both of you share is some of the patients that you take care of, there are treatments for. Not all of them, but some of them. And some of the treatments are often very newly discovered, or they're based on sort of best information that we have right now. And it's not always entirely clear what exactly is going to happen. Maybe, Nick, I'll go back to you, and then we'll switch back and forth. How do you handle that uncertainty?
So very timely question today. I can tell you, I was dealing with one of my patients today who's currently hospitalized, and discussing with a bunch of different specialists as far as what we should do and what should be the next step. And the evidence that I was bringing to the table, as far as what I was saying that I think we should do, was probably the biggest, well, not probably, it is the biggest study that's out there, and it's 4 patients. And completely realizing that I'm bringing my strong high level of evidence is 4 patients. But when there's 30 or 40 described in the world, that's as good as we have. And really knowing the molecular mechanisms and how it makes sense can help us say, yeah, this makes the best sense, and this is the most educated decision for treatment that we can make. And sometimes that's how we have to do it. And then talking to another patient today for a disease that's been described 200-300 times in the world. So, much more common than the other one. And, so we had a lot of that same uncertainty. And for me, it's just talking through to the patients and honestly being honest with them about what we know, what we don't know, where the gaps are, and really going from there. Because I personally don't try to hide it, and just forward about, this is what we know, this is who we reach out to, and we do the best we can.
Beth, any comment on that as far as the uncertainty with treatment?
I would absolutely echo what Nick said in that, I think in terms of approaching uncertainty, I've just taken the approach that it's just best to be honest and to be humble, and to reach out and connect with others around the nation, around the world when I have questions. And I think I really take a page out of the books of the patients and families that I meet, because it's not unusual to meet a family who just very elegantly deals with uncertainty. So I try not to get all worked up, but I love to ask questions. And I think, my training and Nick's training, this and your training, this is what we're educated to do, or we're given the tools to be able to go to the literature and ask questions and reach out to colleagues and make hypotheses, but there's not always a lot of information out there. And so you just do the best you can. But I think it's important to be honest, like Nick says, and just recognize that there are limitations to the knowledge that we have.
Yeah, I think I'd echo what you said. It can be very humbling to kind of be on the other side of the medical bed, if you will, and really learn from patients and the way that they really gracefully handle things that maybe as a physician or as a provider, you feel a lot more unsettled about than they do. And they're actually living it out in life. So that can be incredibly encouraging to see that.
Absolutely.
So I want to ask a little bit about how to talk about rare diseases. I think a lot of patients and families that you care for um, have diseases that are unfamiliar to, their friends, their family, people that they're around in life every day. And it can be hard to explain what's going on in yourself or your child to other folks when maybe you don't have a medical background yourself. What are some approaches or strategies that you would recommend to people to be able to share what's going on in themselves as far as rare disease with people that ask them questions on a daily basis? And we'll go back and forth. I'll do that to you first, Beth.
Okay. That is a challenge, right? Sometimes I mentally prepare myself going into the room if I'm going to see a new patient, a new family, and try to explain something that's very complex. And then sometimes on top of that, there's a language barrier, right? So to try and communicate concepts, try to get everybody on the same page is very difficult. So just when I'm talking to families, it's really important, I think, to try and avoid medical jargon as much as possible. I try to introduce concepts that might be familiar. I'll give you an example. Like one of the more common things that I treat is a bleeding disorder that many people can't even say, let alone spell, and it's called von Willebrand disease. And so when I talk about what von Willebrand proteins do and how they interact with these cells in our bodies called platelets, I like to explain it like the platelets are bricks, and we need healthy mortar around the bricks for the brick wall to stay strong and not crumble. So that's a concept that people can relate to. So I think if there's a way to bring in an example of something that's real life, that's meaningful to people, that's a really good place to start. And then, and obviously for some diseases, that's easier to do than for others. But that's kind of where I like to start. And then I like to utilize resources that are already out there. So I'll often refer patients to, resources that are available online and support groups. I think that's really helpful. Just, to give families ideas about how they can talk to other people about it. And then I also just encourage them only to share what they're comfortable sharing. And it's more about what they're experiencing and not about trying to explain the disease, but maybe just to explain a little bit about what it means for their child or for themselves to go through what they're going through.
Yeah, I agree. This is sometimes very honestly difficult, especially with some of these concepts. And Beth and Caleb will agree, are things that physicians struggle to understand, let alone somebody without a medical background. And so trying to transition that. Luckily for me, I would say the immune system, when I'm explaining things, really lends itself to pictures. So I sit down with a clipboard and a piece of paper and I draw pictures with the families. And I've got a couple canned ones that I'm used to doing. And then sometimes I have to get creative and do it on the fly. And then, I leave that piece of paper in the room so the family can take it if they want. So they have that I sat down and I basically did a chalk drawing with trying to explain it. And it's shocking how often nobody has sat down, even if they came in with a diagnosis, nobody sat down and tried to explain it to them. Nobody's done that. And that some things just click with them, that they're like, oh, well, that's why I get this symptom, or that's why I get this infection. And I like to think that by doing that and taking that time, it, one, helps the patient understand, and two, we get buy-in for the treatment. The treatment that I'm proposing, that, you know, as Beth and I just said, is sometimes we have to be honest with patients and say we don't know everything. And so I'm sitting across from a patient saying I don't know everything, but this is the treatment plan we're going to do. And so it can be a little bit of a dichotomy with that. But getting the patient to understand their disease, even if it's on a basic level, I think leads to a lot better outcomes and satisfaction for the patient.
Yeah, absolutely. So I want to talk about how new things are always coming. So I had a mentor that used to say that what he said today could sound very silly tomorrow, if something new is discovered or reported or whatever. And I think that's one of the aspects of all healthcare, but certainly rare disease. So Nick, we'll start with you. How does really the constant possibility of a new discovery, a new development, a new treatment or whatever integrate into your approach to patient care?
So for me, it's, you got to stay up on things all the time and reading all the time. And I agree with what your mentor said, is that, you know, and for me, when I started doing immune deficiency not that long ago, we had right around 200 genes we know of, and now it's over 440 different monogenetic diseases that we've had to find. And do I know all 440 by heart? No, I don't. But we know how to group them and how to look for them when we need to. And then there's constant treatments coming out and constant new approaches that are difficult to keep up on, but and to integrate. But I think it's needing to be an open mind and be somebody that adapts and knows the physiology of what's wrong, and being able to think outside the box and to think of, you know, one or two patients and how we can trust our knowledge and try to apply it. You know, I joked about the 4 patients, but there's a recent cohort for another disease that was 40 patients for the treatment, which is enormous. And I know there's one up and coming treatment for a disease called PIK3CD, gain of function, that will they'll go to FDA for approval with 40 patients in their phase 3 trial. And that's going to be huge for them, and they'll probably get approval based on that. So I think it's just a really different approach than most physicians are used to taking, where we have these huge studies, things are very well defined. Yeah, so I think that's overall, it's just a very different approach to how you have to do the literature and the treatment.
I think for me, there are certain diseases, kind of like Nick was describing, certain diseases that are still, in the grand scheme of things, rare, but for me, less rare. So some of the childhood malignancies that I treat, we learn a lot through collaborative group trials. And so because our center participates in those trials, and we're a part of international collaborative called the Children's Oncology Group, we learn a lot from the conduct of those multi-institution trials. So that helps a lot to learn from that experience, and obviously from experience across the globe as well. And I think for other kinds of conditions, I don't have the luxury of having cooperative group trials. So I do try to, you know, like Nick said, it's a constant, it's a commitment really to keep current on things. I try to go to conferences, national conferences, to educate myself, honestly, to learn a lot from adult experience. And then I'll just sort of set you know, almost a timer for myself as I'm seeing patients. In follow-up, I'll say, okay, it's been a year. I haven't read about congenital, you know, thrombocytopenic purpura in a while. So I'm going to read about it again and look to see what's out there. And in fact, I just saw a family this past week, siblings with congenital TTP, who, you know, I just said to Dad, like, hey, I'm watching the clinical trials. There's a recombinant form of this metalloprotease called ADAMTS13 that's available right now, just waiting to see when it will go into phase 2 trials. And so I just try to keep families abreast of up and coming therapies if I can. And for some diseases, obviously, that's easier to do than others.
Thank you both. So I am going to try the dreaded multi-part question. So we'll work our way through it. So I wanted to think about particularly patients and families in the audience and where they might be in their journey. And I'll do my best here. We're going to sort of first talk about the folks that are brand new, a new diagnosis just starting out. Then we'll talk about folks that have kind of been settled for a while and are thinking about how do I kind of pay this forward a little bit, and then loop back to patients who still don't have an answer. So I think from a physician's perspective, because that's what you really have to offer, thinking about someone who's newly diagnosed, Beth, what would you say to someone that's just starting out on the journey with rare disease and maybe they're feeling lonely or overwhelmed or something like that? What advice would you have for those folks?
I think it's important to just recognize that you don't have to know everything all at once. And what I love about what I do is the continuity, the relationships that I have with families over time. So I think I like to preface discussions by saying that no question is a dumb question, and some questions are even unanswerable. But to just remind families that they're an expert in their own child, and that means a lot. So as they're kind of getting to know, this new condition, perhaps they just need to remember that they know their child best. And so if there are questions or concerns that come up that, the child needs to go to an emergency department or what have you, just to say, we just need to listen to those families. So some of it is just about reminding them of that. And then I like to, there are times that I like to let families know about different support groups that are out there. I think that's really useful. And I would say useful for the family and useful for me too, because I can't stay abreast of all conditions all the time. And so I'll have families come to me and say, I had a question about something I saw in our group chat or in my support group. And what do you think about this? And then it's just a great way to dialogue. And then I can read more, research something and get back to them. So that's, for someone who's starting out, I would just say, and then I guess the other thing I would point out is I like to try and give some reputable sources. Dr. Google is not always a good doctor. So I caution families about, just kind of randomly Googling, because it can be frightening. And then sometimes there's information that pertains really to certain subgroups or adults, and prognosis in children is very different. So I just like to put that little reminder out there as well. And then again, just keeping the open dialogue. And I always tell families, like, if you have questions that are keeping you awake at night, please don't save those for the next appointment. Let's talk. I just talked to a father today who said just that. Why haven't you been sleeping at night? We should have talked before. So it's just better to communicate and alleviate some of that anxiety.
Nick, what about you for people early in the journey?
So I agree with everything that Beth said, but really emphasizing the need to ask questions. And so I had this conversation with a family today that it was one of my colleagues had made the genetic diagnosis, but then transferred it over to my care. And so this is really the first time sitting down with me, answering questions about this disease. And we went through everything and had a very open dialogue and answered a lot of questions. But I know they walked out of today and said, "Oh, shoot, I should have asked this." And that happened. And so I always tell patients a couple things. send me a message. And that's really nice in today's day and age that we have these portals that it doesn't have to be a phone call. It can be, hey, here's this one quick question, we can answer it. And that it really does open up that dialogue, as Beth said, so you're not staying up at night with this unanswered questions for when we see you next, which, maybe a short time, maybe a longer time. And then really at first, the approach I take a little bit, because I know some of these diagnoses are extremely overwhelming. There's a lot of information to take in. Like the patient today, I'm seeing them back in 6 weeks. We may or may not do any medical intervention, and I actually scheduled it for a fairly long appointment because I know that the questions are going to come up, so we can just sit down in 6 weeks and say, okay, what questions came up, and let's have it more being a social visit of let's just get you through the initial part of this diagnosis, and let everything sink in, get all the questions answered, so we can move forward too. And so just knowing that, I think that's my approach is really having that open dialogue, especially at the start, and then as Beth said too, trying to steer them towards reputable sources. And some diseases, there's great patient advocacy groups. Some there's not, and it just really depends on the disease. And so I try to steer them towards the good ones. And even some of them, like for me, the Immune Deficiency Foundation is a great foundation. But even within that, they do a great job in some diseases. Some they're really just rare, and so they don't address them as much. It's no fault of their own. It's just what it is. And then also, try to heads up. You will find this on Google. I agree or disagree with this. Like the family today, both of them are college educated people, and we talked about what they did or didn't want for information. And I printed off one of the scientific studies with the biggest group of patients because they said, yes, we want that level of information. So perfect, you can have it. Here is that high level information for you to have. And so we're really just talking to them about what information they do or don't want.
So, many patients will start in that place with sort of, this is new, this is scary, this is overwhelming. But I think one of the encouragements that we probably all would give to patients is that you often move on from that and it becomes life, and you start to say things that you never thought you'd say. Things just come out of your mouth because you just live this and this disease. And I think, many patients get to a place where they start to think, what can I do? How can I pay this forward? How can I lend a helping hand to other people in some way, shape, or form? I mean, the fact that we are here tonight talking and having this rare disease event is, in some parts because of one mom in Grand Rapids who has a kid with a rare disease who said, I got to do something. What, again, physician's perspective, Nick, what would you advise people to do that are looking to do something maybe for the greater good and when it comes to rare disease?
So I would go again. There's a lot of these really good patient advocacy groups that are great. And like you said, this symposium here for, again, Immune Deficiency Foundation, I'm very familiar with because I volunteer for them. I work with them a lot, and they're great. And they do things like mentorship. And so that they, in the world before COVID, which it's hard to remember that world, they would have small groups where if somebody wanted to organize a group in a region where they'd get together and people with immune deficiencies can get together and just hang out, go to coffee, do whatever. And because I think with rare diseases sometimes comes a lot of loneliness that you've never met a patient before or another person before with the same disease. And so I think now with the internet, with honestly like Facebook groups, which I laugh a little bit when I say this because there's some great ones and there's some not great ones, but in some of the rare diseases, hearing how some of the patients talk, I think there's some great ones from what I've heard that really does give them a connection and an outlet to, one, say, hey, my doctor's doing this, and then two, just relate to other patients with the same disease that they may never have talked to somebody else. And so I think that those kinds of mentorship and helping support other people who may feel a little bit alone is, from I've heard, is very powerful for those patients.
Yeah, I would agree with Nick. I think another way that I encourage families who are ready to take that next step is to you simply just speak up and let me know, because I do have families that ask, or sometimes I'll just get a sense, based on a conversation, that I can see that a new family is struggling, and I can say, can I introduce you to, a family who's been through this? Can I have, give your phone number? So we make connections that way. I always get permission, and um, but that way they can have a private conversation, just to have a perspective on someone who's kind of been through the whole experience. And that's not to say that one person's experience is exactly like another, but sometimes you just want comfort to know, is this something I should expect or not? Or, is this a dumb question? Those kinds of things can be intimidating. So I think just talking with someone else who has that in common is very powerful, as Nick said. And then for some of the rare diseases too, um, there are national and international registries. And so I'll just ask families if they want to contribute, um, their information in an anonymous way to a registry. It's something that takes a little bit of work, but we can learn a lot, and we do learn a lot about rare diseases from registries that have been established. Simply because those patients are followed over decades, and then we learn about outcomes, and then the new treatments, if those come up. It's you can often be on the ground floor breaking news of various treatments that come to be available.
Well, let's get to that third group of patients. And again, we'll start with you for this one, Beth. Kind of the folks that still maybe don't have a diagnosis, so there's not a clear understanding of what's going on. From your physician's perspective, what counsel would you offer those patients and families?
That's probably the trickiest group. And sometimes we think we have a diagnosis, and then we don't. So a lot of what we do as physicians is to identify, or to try and make diagnoses based on clinical features. So sometimes there isn't an underlying lab test or a genetic test that is available. So sometimes we can be fooled. We can think we're we're treating one thing, and then you find out that this person doesn't have some of the classic genetic mutations that have been described with that particular clinical picture. So I think that's probably the group this is where I think I just learned the most from families, and they just live it every day. And I think for some conditions we can say, we're managing things, their quality of life is great. We focus on those aspects rather than, do we have a complete understanding of why you're experiencing the symptoms that you're experiencing? Because sometimes there just isn't an answer. But I think what I try to emphasize is, I'm here for the long haul. If it's a roller coaster ride, I'm on it, and I'll stay with you.
Yeah, I agree that this can be the toughest group, and part of it is figuring out, for me, when I should reassure a patient and say, I think we've done a reasonable amount of workup, I think everything's fine. And when they're undiagnosed, I still think that there's something more going on and we need to dig deeper. And then, sometimes even within that, I'm wrong. There's a recent pretty humbling patient that I've been following for 3.5 years or so, and reassured them, but we're still following them for some other more minor issues. And then over the last 6 months, they've just been starting getting more legitimate symptoms, and we saw it again, and enough that made me take a step back and say, hey, we need to reevaluate this. We need to dig a little bit deeper. I think I may have been wrong to reassure you. But and we just sometimes have to wait for those new symptoms to come up to be able to point us in a direction. And we did more of a workup right now, and it's still undergoing, but I actually think she may have a rare, kind of a hypomorphic, what we call, so not fully active, but just a little bit active, form of a rare immune deficiency that really it's rearing its head now and coming to light. And so that's sometimes the hard part too, is that sometimes we just have to wait for symptoms and then have the the ability to take a step back and say, maybe I was wrong, maybe we need to look at this again. And then also it's knowing when you say we're really undiagnosed, well, where can we go and what can we do to help get that diagnosis? And can we phone a friend? We have on the immunology side a listserv, so really all the big worldwide immunologists have an email list that we run cases by each other all the time. I sent a case out today on a patient we had admitted, and I not rarely will refer a patient undiagnosed to the National Institute of Health, or there's also Undiagnosed Disease Network ran by the National Institute of Health. And this last Monday, got a phone call from one colleague at the NIH about one of my patients that they think she's the first patient that they're going to diagnose with this brand new disease. And so, things like that happen. And I've known her now for 3.5 years to get to this diagnosis. And so it can be a process sometimes. I tell patients I love it when they can walk out the door with a name for their disease the first day, but that's not always reality.
That's really an awesome story to hear. So I want to shift things towards sort of future state a little bit with the last few questions, and then we'll go through some of the things that have come through in the chat. So Nick, maybe let's start with you. So just looking at the future, what are you most excited about for the future potential with rare disease?
For me, it's going to be targeted therapies. And so really knowing the molecular basis of a disease and being able to personalize that treatment, that comes with its own challenges because personalized treatment by definition means we don't have 1,000 patients in a trial to say this works or not. It's an N of one trial, but that's helpful. And so, some specific inhibitors of exactly where you have a problem. Gene therapy is not that far in the distant future for a lot of the diseases I treat, and probably will be reality and clinically available in the next couple of years, and then we'll really expand from there. And so for me, it's really targeted therapies that will hopefully make a huge difference.
Beth?
Sorry, I had to unmute. Yeah, I definitely agree with Nick, and I think we're taking a little bit of a different approach these days too, because sometimes, well, at least in the past, we used to think about medications, therapies being developed for very specific diseases. And now that we understand kind of more the molecular basis for disease, we realize, my goodness, this, medication that was used to treat heart failure, it makes complete sense to use it in cancer, and here's why. So I think that's very exciting. Certainly, it's been really great to see how whole genome sequencing makes a difference for our patients and families when we can, as Nick said, when they can walk out and know exactly what's going on, know a name for a particular disease or condition that we've had unexplained symptoms for a while. So that's very exciting. I think what's been a big learning experience for me, though, is just the ongoing challenge with that, because the information that we get from such sophisticated testing is limited by the information that we can provide in terms of a patient's symptoms or clinical features. So sometimes you can think that, oh yeah, the whole genome sequencing, it was completely negative. Well, it turns out it wasn't. It's just that your patient hadn't developed particular features or symptoms yet. Like Nick is saying, it took 3.5 years for certain symptoms to come to light. And then once that happens, then you can sort of query again and say, oh, it makes sense that this fits with this particular mutation, this pathogenic mutation that was noted. So that's been humbling for me too, but exciting.
So thinking about the future, maybe the personal future for some people who are watching this, maybe students or people that are thinking about a career in healthcare or maybe something that would involve rare disease. What would your advice be if someone wanted to learn more or find out if this is a passion that is worth them pursuing as something for their life's work? Maybe start with you, Beth.
I would just say keep an open mind. Sometimes, you might surprise yourself. I mean, listen, I never said I want to take care of kids with rare diseases. I just didn't. I really just felt like I was called to this field. I just kept coming back to some of the really meaningful patient experiences that I had had. And I just stayed curious throughout my training and just sort of followed along. And I think it's just important to pursue something that you're passionate about. Just like Nick said, like he's been fired up about the immune system since day one. And I just think that's so great. So listen to that. Listen to that voice that says, gosh, this is so interesting. I could stay up all night long and read about it. I think that's absolutely great to do. And I would just say that doesn't mean you have to be a doctor, though. There's so many different types of careers that will influence rare diseases. So, you might be the person, in the lab, working in an immunology lab. You might be a doctor. You might be a nurse who, takes care of kids with unusual, or less common conditions. There's just so many. You might be a geneticist. You might be a genetic counselor. Like there are just millions of things out there to do. And I would just say keep an open mind and ask questions.
Yeah, I would echo that too. And it's, well, I've been passionate about immunology all along. I don't know, besides knowing and like loving the immune system with that one patient experience, that there was a aha moment that I want to take care of rare patients, or, looking back, I don't know that there's one key moment that got me here. I'm really not sure. But it's definitely, I can say, looking back, where I want to be. And it got me there. And I think, as Beth said, it is just about following the passions, that this is what I found I couldn't live without. And this is, tell people, if you talk to me for more than 5 minutes, I love the immune system. And probably less than that, some would argue. But I think Beth brought up a lot of really good points. There's a lot of ways to do this. There's a lot of ways to significantly impact the lives of people with rare diseases, and just keeping an open mind about, not only do you want, if you want to impact the lives of people with rare diseases, but where your passion lies within that, and following that passion is probably the best advice to give.
Yeah, I think I've personally been struck recently about the power of data when it comes to healthcare, that you don't have to look at a patient in front of you, but when you look through the various data sets that exist from us, whether it be your genetic data, or your electronic medical record data, or aggregating health system data, there's a lot of things to be found in there from almost a computer science background versus, drawing blood or doing procedures. Well, that's the questions that we had prepared for tonight. I want to pull a couple in from questions we've got from the chat. And this is also your opportunity. If you have something that you want to ask Dr. Kurt or Dr. Hartog, please go ahead and put those in. Maybe we'll start with a question that came in around misinformation. This is an age of technology where you can find anybody to agree with you on pretty much anything, and you can find anybody to disagree with you on pretty much anything. So when it comes to families and resources, maybe I'll open this one up since it's more around Robin. How would you equip patients to be protected from misinformation?
I can. So one of the nice things about rare diseases is there's less information, so there's also less misinformation. That is one of the nice things. But as I said before, one of the things I do try to do when I'm talking to families is say, when you Google this, because I know they will, this is what you'll find. This is what I agree with, and this is what I don't. And so just to head that off, to try to say that. And when I say that, I've Googled it myself. I do it because I want to know that when I Google X disease, what shows up? What are people seeing to help exactly that? Because I think that is a very applicable question and concern.
Yeah, I think it's tough, right? Because the volume of information that's out there is so vast. So I just encourage families to, well, first of all, I think like Nick said, try to give some really good, reputable resources. I also like to just give real like patient-friendly resources, again, that speak in a language that most everyone can understand rather than using big fancy words. So that's obviously key. And then I think just encouraging patients, if they have questions, just to bring those back. And then also just emphasizing, if it sounds too good to be true, it probably is. And if it's a cash only offer of some amazing treatment, nope. That also is too good to be true. There are just, unfortunately, a lot of people out there that like to take advantage of those who, are desperate, or, where there's a lot of uncertainty, which is absolutely sad and tragic. But I guess those would be my words of wisdom. But I have people just say, hey, I read this, or I saw this in my support group, or what do you think about this? Is this hocus pocus? And I'm always willing to, read and learn more.
Another question, a lot of rare diseases aren't one thing, or at least maybe they're not always one organ. A disease that presents one way can have an impact on the heart, the lungs, the liver, all over the place. And typically there's not one doctor who does everything. And there's a lot of handoffs and coordinating care. Maybe just what is your thought and what's your approach to these complicated patients that have multiple specialists that need to be involved?
So I'll say this is my average immune deficiency patient. That I tell patients a lot of times, I'll see a situation where each specialty is kind of siloed and hasn't looked at the broader picture of, is there one disease that can explain all of this? And that's a lot of times my goal is, what overarching disease or gene defect can we find that explains everything? And then oftentimes we find it that explains everything. And then I will a lot of times basically become their primary care doc, and really be the quarterback and really be the one that they run everything through. And my patients or anybody will tell you, I get to be pretty type A, and always want to be involved. And when my patients get admitted, I always tell our residents, I'm pretty nice, but there's one way to frustrate me, and that's to not let me know my patient's admitted, because I want to be, because there are a lot of things with every organ system that people often aren't thinking about the whole patient. And so I've really, for me personally, I just am very hands-on and take that role over.
Yeah, I think one good thing, for patients who have rare diseases that maybe aren't quite that sick or need to be in the hospital, we do have we're blessed to have the Sequia care partners, and so that team helps to coordinate visits with many different specialists. And it's not to say it works perfectly every time, but if we can minimize then the a number of scattered appointments, that helps a lot. And especially if someone's going to make a trip to Grand Rapids and they're coming from a few hours away, it's nice to group those over 1 or 2 days if they do need to follow up with multiple specialists. So I found that to be very helpful for my families that need to really touch base with several specialties. And I would agree with Nick. Sometimes it's just the nature of the underlying condition. Like for me, most of the time, it's just that my patients are actively being treated for a particular kind of cancer. And so during that time, like Nick was saying, a lot of things are coordinated through me because I have to make sure that any medication that's prescribed doesn't interact with the chemotherapy treatment that I'm giving them. And I have to make sure that, we're staying on top of kidney function and liver function and all this, just to make sure that we're giving treatment in a safe way. So some of those primary care responsibilities do fall to me during active treatment, at least. But I always like to emphasize to my patients that it really is important to maintain a relationship with their primary care physician. Even though it seems like it's a lot to be seeing a lot of different specialists, but primary care physicians they really help to deal with some of the health prevention aspects and things that I wouldn't necessarily have top of mind in my specialty. So I really value the input that a primary care doctor provides. But I'll acknowledge it's challenging, and I do feel badly for families where it seems like, my goodness, it's a full-time job just going to the doctor. So to the extent that we can try to minimize that by coordinating appointments, we try to do that.
Well, wonderful. Well, thank you both so much, Dr. Kurt and Dr. Hartog, for your time. I think, my takeaways from this conversation is that, the road is long sometimes, and no matter where you start from, there are good people there to help you along the way. Really appreciate your perspectives and questions, and thanks for participating in this forum with us. Thank you, everybody who was able to participate. I encourage you to use the Whova app and the conference platform to interact with folks, to ask questions. That's a great place to get to know each other. There are exhibitors there. Really, those are mostly community resources and groups from West Michigan to just provide you with other ways for connecting and learning more. We will continue this symposium tomorrow night, Friday night, and then Saturday morning of programming. And again, most of this should be available recorded for you to view and share afterwards. So I think that's all the housekeeping to finish us up. Thank you, everybody, for your time tonight, and have a great rest of your night.